Everyone. This is our monthly case presentation series by the Spice Route Karnataka chapter. This is done to benefit all PGs across Karnataka, especially because some of our newer colleges might not have the advantage of having regular case presentation. Today we have Dr. Sanjana Shetty. She's a second year family medicine resident from St. Philomena's. She has volunteered to present an important a case of an important topic, that's foot ulcers. And we have our esteemed moderators. We have Karanam Venkatesh sir, who's also from Philomena's. He has 7 years of experience in teaching and as a full-time family medicine consultant. Along with that, we also have Dr. Anil sir from Baptist Hospital. He's a senior consultant in Department of Surgery. Sir has more than 26 years of experience in surgery, general surgery and laparoscopic surgery, and his special interest is in foot care, and he runs the foot clinic of Baptist. We have more than 30 attendees at the moment. Over to you, Sanjana. We can start with the presentation.
Just a minute. There's a lot of echoing from the sound.
Before we begin, can I request all the participants to mute their audio and video? Whatever doubts, questions, queries they have, they can drop it in the chat box. And at the end of it, we will pick those questions and the moderators or the presenter will answer.
Okay, you can start.
Has anyone joined from two devices? That may be one reason why it's echoing.
Dr. Kirti, can you just log out of one of your devices?
I am on only one device now.
Okay. Sanjana, you can start.
Good evening, everyone. Good evening, sir. So my today's case presentation is on ulcer. So this is a case of a 64-year-old male. He's a resident of Bangalore, retired. Previously, he was working as a shopkeeper. Informant is son and reliable. Now he came to ER with complaint of wound in right foot since 2 weeks associated with discharge. Patient, he was apparently all right 2 weeks ago. Then he noticed a wound on sole of his right foot, which was insidious in onset. Initially watery discharge, now it turned later thick and yellowish in color since 2 weeks, which was managed at home with dressing. No history of trauma. History of slipper slipping away from foot since 6 months, not associated with tingling or numbness. No history of fever. No history of pain in legs on activity. No history of dilated veins on leg. No history of weight loss, and no history of foul smell or maggots. Past history, he's a known case of diabetes since 7 years, not compliant with medication, hypertensive since 4 years, IST and heart failure since 2 years, CKD since 2 years. There's history of wound in the opposite foot 2 years ago, which was managed with dressing at outside clinic. No history of recurrence of ulcer at the same site, and no history of any surgery in the past, and no history of TB. Treatment history, our patient was on this insulin biphasic 30/70 and diabetic medication and hypertensive heart failure, and he was on torsemide and spironolactone. Personal history, his diet was mixed, sleep was sound, appetite normal, no recent change in bowel or bladder habits, and no history of any addictions, and activity of daily living was normal. He was able to independently do all his daily activities, no history of any known allergens. Family history, no significant history of this diabetes, hypertension, TB, or cancer in the family. Socioeconomically, he belonged to upper middle class, and he lives in a well-ventilated house and has access to clean water and toilet facilities. So summary, a 64-year-old male, known case of diabetes, which was poorly controlled, hypertension, heart failure and IHT and CKD, came to with wound discharge on the right foot, etiology probably secondary to diabetic neuropathy or peripheral vascular disease. Examination. Patient, he was conscious, oriented to time, place, person, moderately built and nourished. Patient is febrile, 101 degree Fahrenheit. His pulse was 110, normal in volume character. And peripheral pulses of upper limb was felt well. Lower limb, bilateral dorsalis pedis artery was feeble. And posterior tibial artery, bilaterally, it was absent. BP was normal, 110 by 70. Saturation he was maintaining on room air. Height, BMI was 26. GRBS was normal in ER. Edema was present on right leg up to the mid-calf region. And there was no sign of pallor-icterus cyanosis, clubbing, lymphadenopathy, or leukemia, leukonychia. No thickened nerves and no signs of dilated veins. So on examination of right foot, there was a solitary ulcer in plantar aspect of foot over the heel region, which was approximately 5 by 4 by 1 centimeter in size, horizontally oval in shape, and margins were well defined and irregular. Edge was sloping. Flow was covered with blackish discoloration at center, with yellowish slaw at periphery. There was purulent discharge from the edges. Surrounding skin around ulcer showed callosity, and there was mild edema and redness over lower one-third of leg. Left foot also had a small callus ulcer, which was around 3 by 2 by 1 centimeter, over the medially over the plantar aspect of foot along the cuneiform bones. Surrounding skin appeared normal. So this was the right foot ulcer. And the left foot, which was 2 years ago, which was treated with dressings outside. On palpation, there was local rise of temperature over the surrounding skin. It was non-tender. Size was confirmed with inspectory finding, and base was occupying the subcutaneous tissue. Ulcer was mobile, no induration noted, and it did not bleed on touch. Joint movements were normal. Left foot callous ulcer at the center of sole. And X-ray looked like this. Systemic examination. So sensory system of right foot and left foot. It showed like bilateral pain and touch was absent over the plantar aspect. A proprioception was absent. Ankle reflex was absent. Knee reflex was present. Cardiovascular system was normal. And respiratory system, bilateral vesicular breath sounds were present. And respiratory rate was normal. Abdomen examination was normal. So provisional diagnosis, 64-year-old male, a known diabetic, non-compliant to medicines, hypertension, heart disease, CKD. He came with a non-healing infected diabetic foot ulcer over the right heel with cellulitis, secondary to macrovascular complication and peripheral neuropathy.
A good presentation.
Yes.
So now you tell me, in the history you told me there is slipping of the slippers.
Yes,
Why
sir.
was it happening
Yes,
for
sir.
the patient?
Because of could be possibly due to diabetic neuropathy, he could not feel sensation on his foot.
Yes, that is one reason. The second reason is the muscular weakness.
Yeah.
The small muscles of the foot will get atrophied because of the neuropathy. Not only there is sensory, there will be also motor.
Yes.
So they will not be able to catch the slipper.
Yes.
So that is one of the reasons why it is going to the why the slippers are slipping.
Yes.
Was he barefoot walking or was he using slippers?
He had done dressing and come and he was using slippers.
Yeah, that is now. But before the onset,
Before he used to walk he used to walk with slippers only, but he didn't used to feel those. No history of trauma or no history of walking barefoot.
Hmm. Okay. So how far was he able to walk? What is the distance that he was able to walk?
He didn't give any history of this pain on walking and
So there
like
is no
limitation
chronic.
of activity. Yeah, no history.
Oh, oh. So, fine. Picture what you showed. Hello? Am I audible?
Sir, it is echoing from your side. Maybe can you just disconnect and rejoin once, sir?
Oh. You please continue with Dr. Venkatesh, and
Sure, sir.
rejoin.
Sure, sir. Sure.
So you can go ahead and ask a question, sir.
So, Sanjana, can you go to the slide where the treatment, what treatment he's on for diabetes?
Yes, sir.
So, um, so he's on biphasic insulin
Yes, sir.
twice a day, along with that glimepiride and metformin.
Yes,
So these two medications he's taking for the diabetes, right?
yes.
So,
Yeah.
so addition of what other medications or insulin, in your view, can help in controlling or bring the sugars under much control in this patient specifically? Even though I think we have not yet discussed what are the investigations that has been done in this patient, how much is the HbA1c?
Yes.
Can you throw some light on about this patient? I mean, what were the investigations? I mean, which were done? What was the fasting sugar, postprandial sugar, HbA1c?
Yes, sir. So his HbA1c was around 12 and fasting, like he was not compliant to this evening dose he used to skip. So
Right.
first, because of this non-compliance, his HbA1c was high. So we'll ask him to follow this insulin regularly and like properly as per
Mm,
the dose advised. And if if that was not the case, and if he was compliant, then next medicine class we would like to consider in case of diabetic ulcer to improve this microvascular complication.
mm.
Mm.
What other medications can we add in this patient?
So he's a
Um,
heart failure patient, so we can consider this SGLT2 inhibitor.
oh, which one? Which one can you tell me?
Yeah, Udapa.
Dapagliflozin. You can add
Dapa.
dapagliflozin in this patient, which will
Yes,
help in at least already. I think the damage has happened, but at
yes,
least in future, I think it might help in preventing further damage to the uh, microvascular circulation and both
yes,
micro and macrovascular circulation.
yes.
Mm. And any other things that can be added for this patient to bring sugars? I mean, any values that you got? How much is the fasting? How much is the postprandial, or how much is the mean blood glucose, or uh, how much is the glycemic variability? Have you
Uh, yes.
have you done any tests regarding that?
Uh, yeah, his fasting was 256 and postprandial was 148.
Postprandial was 148.
Yes,
Yes, and fasting is 256.
yes.
So adding what insulin can help in decreasing the fasting blood sugar in this patient. Can we add a basal insulin in this patient so that the fasting
Yes,
sugars
right.
will come under better control?
Yes.
So there is so much of glycemic variability as well, which is
Mm.
almost more than more than 100,
Yes.
which is also one of the key factors for developing. If the higher the glycemic variability, there will be
Mm.
increased microvascular and microvascular complications as the time
Yes.
goes by in a diabetic patient. So that also should be kept in mind.
Yes.
What was the BMI of this patient?
Yeah, BMI was around 26.
26, 26. So there might be still insulin reserve in this patient.
Mm.
Mm, yeah.
Yes.
Sir, over to Anil, sir. So any
Yeah.
other questions that you?
Yes, sir.
Yes.
I joined back.
Yes.
Am I audible now?
Yes.
Yes. No,
Yeah.
there is no echo also.
Yes, sir. This
Yeah.
audio quality is
Thanks.
better.
Thank you. So this patient, can you show the clinical picture there,
Yes.
photograph? So what do you see here actually? You see exactly there is it's the blackish discoloration is almost like a gangrenous patch there.
Yes, sir.
Okay. And and the surrounding edges are very unhealthy. You can see that the cellulitis is still there and the skin peeling, everything is still there.
Yes, sir.
So how will you investigate this patient now? What investigations do you want to do?
Yes, sir. Since this cellulitis and the pulse was also not felt posterior tibial artery, so I would like to go for Doppler arterial limb.
Yeah. So you have to do a bilateral arterial Doppler,
Yes.
right? So what do you see in that?
Uh,
What will you look for in the report?
yeah, so monophasic wave will suggest a blockage, complete occlusion. Biphasic will
Yes.
suggest mild stenosis, and triphasic will be normal.
Yeah. So it will tell where exactly is
Yeah,
this
the site of block.
monophasic, biphasic, and triphasic.
Yes.
Which is a commonest site in diabetic patients for the occlusion?
Mostly the plantar aspect.
Mostly it is infrapopliteal region.
Okay. Yeah, occlusion. Okay.
It is more in the popliteal fossa and beyond the popliteal artery. So there are three arteries, right?
Yes, sir.
Can you name them?
Femoral, popliteal, and further dividing into this anti and posterior tibial.
Okay, anterior tibial, posterior tibial, and peroneal.
Yeah, peroneal, common to, yes.
So you not only have to see the waveform, you have to
Yes.
see about the calcification also,
Yes, sir.
right?
Yes.
So that is one thing. And
Yes.
the temperature of the foot,
Yes, sir.
how will you look for the temperature of the foot actually?
By
Is
the
it cold or is it hot? How will you compare?
will palpate by the back of the hand.
Yes, and you should compare it with the other part of the
Yes.
body and see
Yeah.
whether it is cold or
Yes, sir.
right.
Yes.
Then you have done an X-ray. Can you put that X-ray?
Yes.
Yeah. What does this show? This X-ray show you?
This calcaneal area mild erosion, I think.
Yes. So there may be. I mean, it's not very clearly visible.
Yes.
So there is one calcaneal area where it is little bit maybe erosion is there because the X-ray is not very clear. What
Yes.
about the foot as such? Other bones of the foot?
Yeah, your arch is a little disturbed.
Why is it disturbed? Can you see there is some abnormality in the
Charcot
foot, right?
joint could be.
Yeah, so there may be early Charcots, and you can see the first metatarsal.
Yes.
Actually, there is a small fracture there. Can you see?
Yeah, yes.
Down. Here.
Oh, yeah, yes, sir, yes.
Yeah, so it may be a old fracture which might have healed.
Yes.
Okay. So
Yes.
what does it tell you? If it is a old fracture and if it is healed by itself? And you told me there is no history of trauma. So what do you think is the cause for that?
So some fall history, and he was not
Yes.
moving much. So neuropathic also.
Yes.
He was not using his foot.
Correct. The third thing is all these diabetic foot patients have osteoporosis, severe osteoporosis. So they can undergo microfractures over a period of time, and then they can heal. And that's how and patient has no sensation, right?
Yes, no
So even if he had a fracture, he
Yeah.
wouldn't have felt the pain,
Yes, sir.
and he would continue walking like that,
Yeah.
isn't it?
Yes.
So that's why that fracture has not healed in a proper way. Huh?
Yes.
So,
Yes.
so how will you look at it clinically? So clinically, what will you see when this is a situation?
Gait we will assess.
Yes, the thing is when you inspect the foot,
Yes.
the medial arch may be flattened.
Yeah. Yes.
Okay,
Yes.
so that is something that you need to see. You can see the other tarsal bones also.
Yes.
What does it show? Some of the tarsal bones also are not clear like what you see normally. So it may be early
Yeah.
Charcots also.
Yes.
Okay.
Yes.
So that is what you see in the X-ray. So whether there is any osteomyelitis or anything like that.
Yes.
Okay.
Yes.
Now come back to the clinical picture. Yes. Now, no, the second picture, the left foot.
Yes.
Yes. So what do you see here?
Here this callosity
Yeah.
hypertrophic
So
scar.
that is a healed ulcer, right?
Yes.
That's a healed callosity with
Yes.
hypertrophic skin. What
Yes.
else are you seeing in this foot, in the sole? See, there is lot of fissures and cracks.
Yes.
Can you see?
Yes, sir.
Yeah. So why do you think that has happened?
This owing to autonomics, the
Yes, very
dryness,
good. Very
sweating
good.
is absent.
So when there is a cracked foot, that is a portal of entry for the organisms,
Yes.
right?
Yes.
So that also you need to inspect.
Yes.
Okay. And have you inspected in between the toes?
Your
Especially on the
yeah.
third toe, because there appears to be some fungal infection which is there. What I can make out from this picture may not be there, but that also you need to see, because that is also one of the risk factors.
Yes.
So when you are, as a family physician, when you are examining a diabetic patients, you have to look at all these foot parameter, the warning signs of the diabetic foot.
Yes.
All right.
Yes.
Yes. So now, okay. Now, how do you look at the Charcot's foot, especially? This is X-ray. Clinically, how will you examine? Clinically, you should ask the patient to stand,
Yes.
okay, and then see for the arches.
Yeah, arches.
Yeah, see for the flattening of the foot.
Yes.
And then if you see from the front,
Yes.
if there is a Charcot, the ankle also would have moved towards one side.
Okay. Yes.
Okay. And from the back, you need to see. You need to make the patient stand.
Yes.
You have to examine from the back and
Yes.
see about the position of the tendo Achilles and see the symmetry. Sometimes if there is lot of a lot of Charcots, you will see that.
Yes. Yes.
Okay.
Okay.
Okay. Now proceed. Go to the next slide. Yeah.
This look.
Okay. Yeah. Yeah. So how will you manage this ulcer now?
So this also first we will after Doppler will Plan if there's blockage, then I will plan angioplasty.
See, the first thing is you need to control the local infection.
Yeah, since fever is it's
Yes,
infected, so we'll do debridement.
yes. First thing you told that there is pus coming out from the
Yeah.
ulcer, right? Ulcer edges and all the places.
Yes.
So underneath that black gangrenous patch, you
Yes.
will have a pus. So
Yes.
first thing is you need to debride.
Yes.
Debride thoroughly.
Yes.
And what will you take for the culture?
Yeah. So we'll take edges.
Yes. So when you are doing a debridement, you need to not only send the pus, but a deepest tissue for the culture. So it is a deep tissue culture what is more relevant, because on the surface cultures may be different and
Yes.
the deeper tissues may be different. So the
Yes.
first thing is, and what antibiotic usually will you start in these patients?
Like we'll start anaerobic as well as gram negative and broad spectrum.
Broad spectrum antibiotics.
Yes.
Fine then. So, and then, so yeah, that's it. And then proceed with your next slide. Next. Fine. Okay. So that is, and once you debride, what dressings will you do? Hello?
Betadine. Yes.
Yeah, regarding that wound, once you debride,
Yes, sir.
what dressings will you do?
Betadine soaked.
Betadine soaked, yes, but once the wound is better,
Yes.
you can clean with betadine and peroxide, but once the wound starts granulating,
Yes.
once the pus has reduced,
Yes.
ideal thing will be a saline dressing.
Okay, sir.
Best,
Okay, sir.
best thing will be a saline dressing, or you can use local hydrogels.
Yes. Yes.
Will keep the ulcer moist.
Yes.
That is one aspect of dressing.
Yes.
Now, what else? What is more important?
The blockage was there, so we'll do angiogram.
Yes, very good.
Angiogram.
So once you find that there is a blockade, or if you find the infrapopliteal disease,
Yes.
his creatinine is okay.
His creat was also 2 point. His CKD known case, so 2.3, 2.4.
Yeah. So will you be able to do the angiogram?
No, it's risky one.
Yeah.
We can try to reduce creatinine and then do.
Yes, you need to control the creatinine. That is most important.
Yes.
Because otherwise you will not be able to do the angiogram. Of
Yes.
course, so in such a situation, you can do MRI
Yes.
of the MRI
Yeah.
of the venogram,
Yeah.
and of course it is still risky, but you may not get the entire information what is required. And some of the interventional radiologists nowadays are using carbon dioxide for the angiogram, but that is rare and in some good centers only. But from your side, what else can we do? What is now once the ulcer, you have controlled the infection, the
Yes.
ulcer is there. What will you do next?
Yeah, we will advise offloading shoes.
Yes, very good. So what sort of an offloading will you advise?
So after debridement, we'll give support to this area. So high rise of the heel that we take.
No, heel needs to be offloaded, right?
Yes, yes.
Yeah. So what you have to do is either you have to give a total contact cast.
Yes.
Total
Yes.
contact cast with a window for
Yes.
the heel,
Okay.
right?
Yes.
So that you can inspect the wound and you can do the dressing.
Yes.
And you need to change. Or there is something called as a prosthesis,
Yes.
like bowler iron prosthesis,
Yes.
where they use that. Or there are nowadays some air boots also are available
Yes.
for the offloading. Okay,
Yes.
so those things you need to use it.
Yes.
Use, and then most important is your control of sugar.
Yeah. Yes. Sir.
Until then, and angioplasty, if it is indicated, that is good.
Yes.
And if it is, some people do a arterial bypass.
Yes.
Okay? Okay. So I think the other part also needs to be discussed. And what will you, the left foot, what will you do for that callosity?
Mm,
What will you do for the callosity there?
This is like chronic ulcer. It is remaining.
Yeah, the callosity needs to be removed.
Okay.
Otherwise, it will heal only superficially and underlying the callosity. Here also, you need to give offloading for this.
Yes.
And nowadays, it is a 3D. The foot. There are people who are taking a 3D printing and then giving a offloading.
Okay.
So, but it is very expensive. If the
Yes.
patient can afford, that is also.
Okay. Yes.
Okay.
Yes. So for this patient, creatinine was controlled to 1.8, and then we did MR angio. It showed
Okay.
right
Yeah.
side.
Yeah, tell me what is the angio? I am not able to see that.
Yeah.
I mean, the report is quite.
Yes. So, right side, it showed posterior tibial artery complete occlusion and
Yes.
common peroneal artery also complete occlusion of right side, where the big ulcer was there, and left side also posterior tibial artery and common peroneal artery occlusion was there. Also, this moderate disease in this distal segment of superficial femoral artery also.
Yes. So when you have such a extensive disease,
Yes.
the angioplasty, balloon angioplasty may
Yes.
help only in healing the ulcer, but that will be only a temporary
Yes.
disease, temporary relief if it happens.
Yes.
Otherwise, many of the patients will end up with amputations.
Yes, sir.
The other problem is he also has a CKD.
Yes, sir.
So the CKD also has the arterial problems,
Yes,
not
sir.
only the diabetes.
Yes.
Right. So that is yeah, I think you have investigated very well.
Yes.
That's a good thing. I think I will hand over to the other people. If you have any doubts, you can. See, this is another thing that what you are seeing that, yeah, this is one more very important thing. You showed me that there is a varicose veins also.
Yes, sir.
So how will you manage this varicose veins?
Magnesium sulfate dressings.
No, varicose veins.
So
How will
yeah,
you manage?
so he came with cellulitis picture. So for like usually for varicose veins, compression dressing and
Yeah, will you give compression dressing in this patient?
no, for him we can't give
You cannot give it
arterial.
because once you give a compression for varicose vein, it will occlude whatever the vascularity is there, you are going to occlude.
Yes.
So actually, the compression stockings are contraindicated in these patients. Even
Yes.
crepe bandage is contraindicated.
Yes.
So if you want to manage a varicose vein, you have to first treat the arterial ulcer. This is
Yes.
one more thing what you should always look at whenever you are examining a patient of suspected venous ulcer. Because this
Yes.
patient is not venous ulcer, but when
Yes.
you have a venous ulcer, always palpate the arterial pulses.
Yes, sir.
If it is palpable, then you give a compression stop.
Yeah, okay. Sir.
Otherwise, don't give compression stocking. Manage the arterial problem.
Yes. Sir.
Sir, if I can ask a question on everyone's behalf. So in
Yes.
primary care, we will try to manage the risk factors, and if someone is diabetic, then we try to control as much as possible and examine people's feet at every visit to look for neuropathy, arthritis, all that. If there is a wound, we try to manage um, if it is infected with antibiotics and with dressing. But at what point should primary care physicians refer to a specialist, either a surgeon or a foot specialist? What all would be the
Yeah.
indications where you would prefer we send them to the surgeon?
Yes. See, when there is any sign of systemic sepsis, like say fever, or the wound is not healing, wound is increasing in size, and the pus is showing up, it's not granulating, then immediately it is better to take an opinion from the surgeon. If you feel the granulation is coming, or at least it is not worsening, then you can continue managing with your dressings. And
Okay.
vascularity, again, you have to check the peripheral pulse whenever you are doing in the periphery or wherever you are. If you feel the pulse is feeble, then please send. You can many people, we get a baseline Doppler also done. So that
Okay, sir.
we have an advantage of comparing it, say after 1 year, like that, we can have a comparison, how is progress and all the things. But any
So
signs of systemic sepsis, which please send the patient. That is most important.
okay. So this a baseline Doppler. This is even before we find any feeble pulse or varicosities. This is even before we think they've developed complications to know
Yes,
that.
see,
Okay.
sometimes see that is what comes in the screening of the patient. Now, many times the pulse will be palpable, but when you do a Doppler, it will be biphasic flow.
Okay,
So
sir.
when the patient is having a biphasic flow, that is a point where we can actually look at intervening, where it doesn't go to a monophasic flow, where your intervention of diabetes and of course patient will be on statins.
Yes. Hmm.
So those things can continue. Statins is one more thing which will really help in the chronic ischemic limbs also. Statins is one thing which you can start.
Hmm.
And somebody has asked the question, in total contact cast with the window is the same as below knee cast. Yes, it is below knee cast only. You have to you have to give a window. Window is kept so that you can clean the wound and do the dressing. But yeah, and the patient should be advised not to bear weight in those. Means it won't be like you can tell him to go for a walking and all the things. That may not be possible. He can do his daily routine work, and that is it. Now, what about the next question? What is asked is what about the anticoagulant use in this patient? Anticoagulants, you can see the patient is already on aspirin, clopidogrel. So already the antiplatelets are there. So I don't think there will be any help when you add an additional anticoagulant. That is three anticoagulants. You may have other reasons for the like cardiac patient, like cardiac issues and all the things. So at that time, yes, if they want, they can do it.
Unless the
Other,
patient is sorry to intervene.
sir, one last question
Yes,
here.
yes, yes,
Somebody
yes,
has
yes.
asked.
Please,
I'll just
go ahead.
answer that. And somebody has asked, Lijo has asked about the best antibiotic start empirically before the culture sensitivity. See, what I do in my OPD is we usually start ciprofloxacin and clindamycin together as a starting antibiotic, and we send all the cultures and everything. empirically. That is, the patient is not in severe sepsis or anything. But if the patient is in severe sepsis or he is come in severe cellulitis or shock or anything, most of the time we start with piperacillin tazobactam or meropenem. If he is in shock, definitely meropenem. Like we need to hit the patient hard so that we will be able to control the sepsis. It should go hand in hand. We should control the sepsis, physician should control the sugars, and antibiotics should be as high as possible if it is in the shock. On OPD basis, if the patient is not in sepsis, I start on Cipro and Clinda. Most of the time, the organisms will be sensitive to that unless the patient has used multiple antibiotics outside. Now, the next question asked is about the pentoxifylline, silastazole, and aspirin. See, it doesn't depend upon the occlusion. Now, this is where when you have a biphasic flow, what you can do is you can start the patient on silastazole. That is what I do. We start it on 50 mg twice daily or 100 mg twice daily. And what I tell is, if he is having biphasic flow, ask him to walk. The more he walks, the more of alternative canals, the blood flow, the smaller arteries will open the more he walks. So that is one thing which may help the silastazole. And aspirin, definitely he will have a heart problem, he will have a IHC. He will anyway be taking aspirin, so you can continue. Pentoxifylline, to some extent, it may help, but not in all cases. Pure ischemic limbs like not a diabetic ones in say hypertension or CKD, those patients pentoxifylline may help. Diabetic also, there's no contraindication. Can use any one of them, either pentoxifylline or silastazole. Silastazole is very useful when you ask the patient to walk. Even the claudication patients, you should ask them to walk with silastazole. For a period of 3 to 6 months, their vascularity may improve provided their sugars are under.
So
Now I
this
think
regarding edge of ulcer, this one is sloping or punched out?
no, that
In
is not
neuropathy?
sloping. See, that is necrotic edge only. That
Okay.
is all necrotic edge.
Yeah.
You can describe this as infected ulcer with uneven edges and necrotic gangrenous patch present in the center of the ulcer.
Yes.
Okay.
Okay.
And this callosity is there. Callosity is there. There is no
Yes.
doubt about it. And
Yes.
this would have started with the cracks in the heel
Yes.
most of the time. Or he might have gone on this one. He might have stepped on a hot. Many times when they go for this pilgrimage and now in the summer, they
Yes.
develop blebs and they come
Yes.
because they have to walk barefoot.
Yes.
So that is one more thing that many patients come with this problem. And they don't realize that they have developed blebs because no sensation.
Yes.
Okay. Yes, sir. Venkatesh, sir, you can take over, sir.
So
For
nothing
the
much. I think,
medical
sir, you have
management.
covered almost everything except for that question that which is better, EMPA or DAPA. Considering the CKD of this patient, yes, EMPA is better than dapagliflozin for the control of, I mean, for to stop the progression of further CKD. But as there is sepsis in this patient, there is a possibility that it could be AKI or CKD also. So if we can control the creatinine levels, that is well and good. And DAPA is more better in controlling, I mean, heart-related long-term to avoid complications of long-term heart failure, control of the blood pressure. It is preferred over empagliflozin. but overall efficacy, safety profile of both the medications are almost same. Uh, uh, anything can be added. Uh, you can either take, give empagliflozin or dapagliflozin. I don't see much difference in adding the medication. And as sir told, I think he has covered everything. I think in each and every visit, when they come for the management of diabetes, we should definitely have a look at the foot, look for intertrigo, development of any new callosities, development of any even smaller wounds, and any changes in the gait, asymmetry should be noticed, and especially any early charcot joints repairing, we have to see, and definitely everything has to be addressed. And we should also, if the patients are not coming regularly, we should always ask them to self-examine their foot once in a while.
Yes.
As sir suggested, even a slight suspicion of any peripheral vascular disease which is getting progressed, or any slight suspicion of even smaller infection, or requirement of any offloading for the food, I think we should take definitely help of a surgeon for the management.
Yes.
And when basal insulin is one of the things which can be added in this patient specifically, and we can even add some medications like alpha glucosidase inhibitors, which will also decrease the overall sugars in this patient. And DPP-4 inhibitors are also one of the options. I think he has not taken full. Uh, uh, um, I feel that the patient should have been put on more OHS first, rather than directly going on the insulin in this patient specifically. So uh, that would help in decreasing the sugars in a better way. Yes.
Yes.
Sir, I just want to add one more thing, sir. This diabetic foot patients, many of them, they come with small callosities or trophic ulcers on the tip of the toes. Many of them might have seen that. So in such cases, you can use something called as a silicone toe caps.
Yes.
It is available on the, you will get, that's the silicone toe caps. So you can use that.
Okay.
Yeah, I think any other doubts you have?
Uh, Anyone wants to ask one last doubt to either Anil sir or Venkatesh sir?
Yes, I saw one more question. Glargine can be, as I said, basal insulin, adding basal insulin will definitely help in this patient. Yes. And diabetic management in short, uh, as I said, I think we can already, he's on glimepiride 2 mg and metformin 500 mg, which can, where the dosage can be maximized to 4 mg twice a day, and we can add a DPP-4 inhibitor, and along with a SGLT2 inhibitor, add a basal insulin, maybe continue the same pre-mixed regimen, see if the sugars are coming in control, and then we can hike up the insulin, and we can ask them to monitor the sugars at home, and specifically mention what food they are taking, to check before lunch or before breakfast or before dinner, and 2 hours after each meal, and also in the midnight to look for any hypoglycemias, so that we can increase or decrease the insulin dosages as per the CRBS readings. So in this patient, we can continue metformin as well. because we still don't know whether it is an acute on CKD or a CKD per se. So, yes.
I think that's about it. Thank you so much. I think in 1 hour we have started with the presentation dealt with management of comorbidities and ulcers and what to look for and when to refer. So it was a well-rounded session. Thank you so much, Venkatesh sir and Anil sir, for taking the time to be with us.
Thank you,
I'm
madam.
sure it was helpful
Thanks
to
for the
everyone.
opportunity.
Thank you, sir.
Thank you, sir.
Thank you.
Thank you, everyone. Thank you, Sanjana.
Thank you, sir.
Thank you, sir. Yeah. Thank you.
Thank you.
Kirti, once everyone leaves, you can stop recording, okay?
Okay.